So in our previous video we were discussing about a question that was related to gist. Mainly we have finished with your site of gist, and second one was the mutation. So in this video or in this lecture we will discuss a full in-depth questions and the concepts behind your gist. Okay, so it will be an elaborate and in-depth session. Okay, so that's why we have made in a 2 video session. So the mutations that is occurring in KIT and PDGFR alpha and your SDH, that is your wild type KIT. So the mutations is going to occur where exactly is in KIT 70% it occurs in exon 11, 10% of it in exon 9, and it is most commonly seen in small intestine. So the small intestinal cysts, the mutation would be in your c-KIT exactly in the exon 9, and these small intestinal cysts are more commonly present as compression symptoms like abdominal mass and compressions of the structures would lead to the symptoms present according to their location in the small intestine. Most commonly it occurs in the ileal region, the terminal ileal regions. So they mostly tend to bleed. The most common, the 1/4 or the 1/4 of the gist, most common presentation of gist is most common is bleeding. Like overt bleeding, and this PDG for alpha is most commonly seen in your stomach predominantly. And where exactly the mutation is, this has been asked earlier also. The location is in 70% is in exon 18 D842V. Why it is of importance, or why it has been asked prior exam, is that this type of mutation makes it sensitive for imatinib. So when we move on to the treatment of the gist, we will come across that the chemotherapy has a significant role. So for imatinib to act, the mutation should be like in the exon D842V. So the mutation is basically depends on this factor, that whether the imatinib is sensitive or not. Why it is important? Like so, because in the wild type of SDH there is resistance, as the name suggests, wild type, it is resistance to imatinib. And two important things you must know in SDH type of gist. In SDH type of gist, one thing is that there is absence of KIT and PDGF mutation, which makes it insensitive or resistance to your imatinib, and it's exclusively seen in stomach. So two mutations we have seen till now that occurs in stomach, that is your SDH mutation and PDGFR alpha mutation. And the mutation that occurs in your small intestine is c-KIT mutation, and specifically the exon 9 mutation. And what makes imatinib sensitive is that the PDGFR alpha mutation, specifically in the exon 18D842V. So mostly it is in the onset is childhood. Generally GIST occurs in a older age, but wild type GIST it's tend to occur in the childhood or younger age. Second important thing is that it is exclusively in the stomach. Third important thing is that it is resistance to imatinib. And immunohistochemistry analysis, it shows negative for SDH mutations. So two things you need to know here. That's called as Carney's triad and something called as Carney-Statusky syndrome. So Carney's triad, what is this based upon? It's GIST, pulmonary chondroma, and your paragangliomas. Carney-Statusky syndrome is nothing but it is just with paragangliomas with wild, but the GIST occurring in the Carney-Statusky syndrome is wild type GIST. So it has an indolent course. It is common in young age people, and more important, a more specific important point to be noted is that it spreads to lymph nodes. So here comes a question. The most common spread is hematogenous spread. Lymph node spread is very rare. The one that occurs through the lymph node spread is that your SDH mutation, WT GIST, that is your wild type GIST with SDH mutation tends to spread with the lymph nodes. The most common site of metastasis is liver, and hardly you see a lung metastasis. In immunohistochemistry and immunophenotyping, you must understand that 97 or 95% they are positive for c-KIT, that is your CD117, and 60 to 70% they are also positive for CD34. These are called as markers rather than mutations, and they are negative mostly for their SMA, which is positive in your leiomyomas, and desmin in your desmoid tumors they are negative. For yes, and but you must know that in some rare cases this S100 and SMA also be positive. So the risk stratification, there is some criteria called as Fletcher's criteria in your GIST. Just you must know about this name and what categories are included this under this risk stratification. Includes one is mitosis, mitotic index, next is the site, next is the size. So mitotic index, that is more than 10 hyper field, is orism and tends to be a malignant. Similarly, site, and size also plays a role. More than 2 centimeter of cyst has to be operated surgically. So we already discussed, right? Most common small intestinal tumors have a c-KIT mutation on the exon 9, and most common site of this is fund in stomach, and in the stomach it is most commonly in the fundus, and in stomach there is two types of mutation common. One is the PDGFR alpha mutation and this SDH mutations. So surgery is the choice for the localized early stage tumors. So advanced stage, again the role of chemotherapy comes. So the principles of surgery is simple, that there is simple excision with negative margin. Mostly it is your wedge, you can go for wedge resection also. Second, tumor rupture has to be avoided. In rectum, R1 resection is done. And coming to your last resort, that is chemotherapy. The drugs used are imatinib, sunitinib. If it is resistant to imatinib, you can go for sunitinib, and you can go for dasatinib and your regorafenib. So these are all basically targeting your c-KIT mutations. So imatinib is a inhibitor of both c-KIT and PDGFR alpha, right? So the important thing I want you to know here is that the dosage of your imatinib, usual dosage is 400 mg taken per orally, okay? But in cases of small intestinal cyst, it will be 800 mg. So small intestinal cyst, I have already told you, the mutation is in there. Where is the mutation? Is in the exon 9 of your KIT mutation, where the dosage will be your imatinib is 800 mg. Again there it is per orally, and dosage of sunitinib is 50 mg per orally 4 weeks for every 6 weeks. And regorafenib is taken by mouth, again per orally, it is 160 mg 3 weeks for every 4 weeks. So for intermediate and as an adjuvant therapy, an adjuvant after surgery, if the margins are positive, the adjuvant therapy duration is for 3 years. So let us see some other questions related to your cyst. The cell of origin in cyst is interstitial cells of Kajal. The following are true about cyst except the cell of origin is interstitial cells of found in the matrix plexus. Very low incidence, predominantly in male, does not occur in young children. So they asked which is except. So young children it can occur where when it is an SDH mutation, predominantly in male. Yes, true. It cells of origin of interstitial cells of Kajal is correct, and very low incidence. Yes, only 1% in the GI tract. So this is a tricky question where it is only mentioned like cyst. If it is mentioned wild type gist, then the option D is also correct. So here the best option would be D, because it is not mentioned wild type gist. It is mentioned just gist. So it is more common in your young children. If it is mentioned wild type gist, which of the following statement is true about gist without except, then your option would be D. Most common site of gist is stomach. We have told and discussed a number of times. False about gist is stomach is the most common site. True, can present with bleeding. It is like most common presentation, like 1/4 of this is present with bleeding. Again, it is true. Commonly metastasis to lymph nodes. Again, it's a wrong statement. And can present with peritoneal mets. Yes, it's again true statement. So, which commonly metastasis to lymph nodes? Again, it is a wild type SDH mutated gist. So true about gist all except. Most common in duodenum, necrosis and ulceration present. PET is used to assess the response therapy, and it is a well circumscribed tuba. Yes, most common site is stomach. Again, the question is except. All are mutations found in gist. KIT is mutation found and PDGFR is mutation found. CD117 is not a mutation, it is an immunohistomarker. Radiation related tumors are wild type positive. True statement. Carnage associated. True statement. CD7117 negative. True statement. So all of the above is correct. Wild type just false statement is as negative for S true, negative for PDGF as true. It is rare. Again true. Dog 1 positive. No. So dog 1 positive. I want to talk about here. This is what is the meaning of dog 1 is that discovered only on gist is called as dog 1. It is highly sensitive marker for gist, not for a wild type gist. So most common symptomatic benign neoplasm of small bowel is just every word is important. Yes, and the most common symptomatic benign neoplasm of the small bowel. Again, I have told you here the mutation is in the exon 9. Commonest stomach tumor which bleeds is your fibrosarcoma. So all are true about gist except epithelial and spindle cell variants. Yes, it can be seen in your pathology. Types have new clinical implication. Yes, again that is not going to change your mode of treatment. Mitosis is most important prognostic factor. Exactly, if it is more than 10, again this plays an important role in the malignancy. Histopathology can predict metastatic potential. CD117, pick the right statement. They do not identify the mutations. Yes, they are a marker, they are not mutations. They do not predict the response of the treatment. Yes, true. They are useful only in differential diagnosis. Yes, dog 1 is more specific than CD117. Yes, so I've already told about this, that dog 1 is more specific than CD117. All are included in dissatisfaction except site is included, metastasis is included, size is included, site is also included, size stage is not included. All are imatinib resistant just except wild type gist is resistance. PDGFR mutation in exon 18 D48842V and KIT mutation in exon 9. KIT mutation in exon 9 is sensitive and the dosage here is 800 mg. So that's all I wanted to discuss about in depth about GIST, so that you will be able to answer in the future upcoming exams too. So the topics gets repeated rather than your questions that is getting repeated. Thank you. We'll see you soon in another topic, high heel topic for your next exam or the NEET exam.